Welcome to the next episode of Black America's Health. Today, we are talking about asthma. I'm Dr. Ty, and I'm here with Dr. Tyree Winters, a pediatrician, which means he takes care of children, and Dr. Nathan Lott, who is a lung specialist and an ICU doc. So we hear about asthma all the time, and most people either know someone with asthma or they have some of it themselves. So Dr. Lott, when someone has asthma, can you tell us what is actually happening in the lungs?
Well, asthma is a disease that is characterized by inflammation within the lung. The best description that I can give it that you can see is if you've ever had a burn on your arm, let's say some grease popped on your hand, and you looked at the skin and you see that it's a little red and raised, that's inflammation. That inflammation is happening in the lung, and it's due to several different factors.
Okay. And Dr. Winters, how do patients describe that asthma feels like?
So there are different feelings that individuals may have for asthma. One of the feelings that they can describe is difficulty taking a deep breath in, almost as if someone is sitting on their chest. Another feeling that individuals may have is a cough that seems a persistent cough that they cannot get rid of. Sometimes it just may feel like a discomfort of almost having a dizzy feeling or feeling as if they are uneasy and can't figure out exactly why. So it's not just always one specific feeling that individuals may have.
And Dr. Lott, so how is this different than, say, like emphysema or something like emphysema that smokers can get? How is asthma different from that?
The simplest way of looking at it, asthma and emphysema, which is also known as COPD, are diseases that cause the lung to not work efficiently. We call it obstruction. The difference between them is that asthma is manifested by reversible changes, meaning that it's bad sometimes, it's good sometimes, it's bad sometimes, it's good sometimes. And that's something that we can see over time if we do breathing tests to evaluate it. Whereas patients with emphysema, it is an irreversible disease. It is progressive and it gets worse over time. There are things that make one person more likely to have one or the other. For instance, chronic obstructive lung disease is usually manifested in people that smoke. Asthma can occur in smokers, but it is often discovered in a different distribution of patients. The kids, young adults, and even more recently, we've also noticed even older adults, plus 65, have been primarily diagnosed with asthma as well. And the things that make you less likely to consider a chronic lung disease, chronic obstructive lung disease, would be a lack of a smoking history, the intermittent cough, the shortness of breath with exertion that seems to be confined to certain times of the year, like spring, fall, where you have the change of seasons, your pollen counts go high, and allergens tend to dominate the symptom syndrome. So how do we evaluate it? Breathing tests and then clinical examination. Depending on who you're seeing, there may be blood tests that are done to check.
And Dr. Winters, what kind of things trigger asthma? Why do people even get this? Why does it happen?
So similar to how Dr. Lott explained with the inflammation, there are certain things that are either environmental or some things that can even trigger our body to have a response that we can't explain. So, some of the things that can happen is very similar to how certain individuals will notice when they go outside, especially during the time of the year around spring or fall, when there may be different allergens or what I like to call as hay fever or pollen or dust or those different type of things can cause for the skin inside of your nose to become congested or feel inflamed. You can also have the same things that can happen to the skin that is inside of those airways in your lungs as well that can cause it. There's other things that can cause it as well, such as exercise, being in a cold environment, being in a warm environment. Also, things like cigarette smoke or different perfumes and colognes. So there is a multitude of different things that can cause for this process to be triggered or to be agitated per se, including pets.
So, but Dr. Winters, in addition to being a pediatrician, you're also an obesity specialist, right? So exercise is always important. What do you tell your patients that have asthma during times of high pollen counts, for example? Do you tell them not to go outside and play? Is it safer for them to stay inside? What do you normally tell them?
So the first thing I normally tell them is your doctor is your partner. So if you know that, for instance, if one of my patients who may be a child or the parent comes in and says, well, they want to go outside and play, but when they go outside and play, it usually triggers their asthma because of having the pollen or grass or whatever have you. Then I'll normally have a conversation and say, there are other ways that we can help to be able to decrease that inflammation to allow that child to be able to still interact and play. We know that there is a relationship between obesity and asthma in terms of the higher the risk of your obesity, it can also affect and worsen the outcome of your asthma as well. There are things that we can do to help prevent that because if you think about it, a lot of us watch the Olympics or even watch sports teams like basketball or football. There are so many players and athletes who have asthma that can still compete on a very competitive level. But how do they compete? It's because we work with them to be able to provide ways to be able to help to control their asthma so they can still do those activities.
Got it. What does it look like when you're first seeing a pediatric patient, maybe even a baby or like an infant with symptoms? How do you kind of figure out whether this is asthma or not?
So it can be tricky. And the reason why it can be tricky is because there are many times over the first 2 years of life where there are certain infections. When I mean infections such as colds and viral infections from so many different viruses and bacteria that can cause children to have classic symptoms of asthma. That includes that chronic or persistent cough, that can also include wheezing, which wheezing is when the airways or the tubes in the lungs get smaller. It almost makes a whistling sound. So imagine if I blow with my mouth in a circle, go versus when I make it narrow, it goes, and that's what we can hear in the lungs, and that's what we describe as wheezing. So when we see that in younger children, the first thing we have to think to ourselves is, do they have symptoms associated with an infection? But for kids, especially kids who have a higher risk for things such as asthma, so that means that they have a family history within their parents or grandparents or siblings who have asthma, as well as if they have a history of eczema, which is dry skin, um, a type of dry skin, or if they have history of food allergies or drug allergies, then they have a higher risk of being able to develop asthma. We typically don't diagnose asthma in children under the age of 2, but there are in certain situations, times, and in situations, periods where we do have children that can be diagnosed as early as in their 6 to 12 months of age.
Got it. So let's talk about treatments. So I know that, the typical thought is you have asthma and you think about like the inhaler that you put to your mouth and you push it and you take a deep breath in. How do those work, Dr. Lott? Either inhalers versus like nebulizer treatments. Those are the ones with the mask and the steam is coming out.
Mhm.
How do those work?
Okay. So when I describe treatment for asthma, I typically divide it into two really, really broad categories. One is your short acting beta agonist or your rescue drugs. The other is your controller drugs. The controller drugs tend to involve steroids, they involve really long acting versions of albuterol. The difference between the two really is what's the onset and what is the duration that the drug is going to do its job. The short acting drugs like albuterol tend to work very quickly in bronchodilating or opening up the bronchi, the airways that air has to travel to get into the lungs. And it does that for about 3 to 4 hours. Most patients that utilize these drugs like albuterol swear by them. They will say, this drug saved my life. I use this consistently because it makes me feel good. I can breathe. And my answer is that is right, because that's what it's supposed to do. A well controlled asthmatic is one that does not need their albuterol frequently. If you need to use it more than twice a week, you are not controlled and you need to follow up with your primary care physician or your pulmonologist to make sure that the regimen you're on is one that's designed to help get your symptoms controlled.
And Dr. Winters, so going back to the inhalers versus maybe the nebulizer treatments when you have like the asthma machine where you put the medicine, so both can deliver albuterol. Is one better than the other?
So that's an age-old question that I think we find over the years have changed in terms of the school of thought, not only for lung specialists such as Dr. Lott, but also for our primary care providers like myself. So initially, the nebulizer or the machine that has the vapor in the spray that you're used to seeing people with a mask on was seen to be in cases of more severe attacks, asthma attacks, or more severe asthma. But what we have found is the medication that we can give through an inhaler, so the smaller handheld pumps that we're used to seeing, those medications, when used with what we call something that's called a spacer, so a tube that actually holds that medication in place to allow for the person to be able to get the deep breath in and out of the medication, that is actually just as effective and can be used in a quicker delivery, as well as without having the inhibitions of not having to worry about electricity and worry about being able to be in an environment that you can set all of that stuff up with at the same time. And
As
so,
a,
I'm sorry,
as a
please.
comparison, a nebulizer treatment takes about 10 to 15 minutes to get the whole treatment in.
Yes,
Your albuterol inhaler gets you the whole thing in about 4 to 5 seconds.
exactly. And we even find that especially when we're thinking about kids, for instance, um, I can tell you there is a quick anecdotal story. One of my nephews, I had to give a breathing treatment to, was one of my patients, which was with a nebulizer. And it's a very scary thing to see this mask when you're having a difficult time taking a breath in that has all this vapor. The kid is thinking like, oh my God, I'm not going to be able to breathe, and I had to put it over his face. Well, it was going this way, his face was going that way. It was very difficult to be able to put that mask on him to be able to get the medication that he desperately needed before I would have to admit him into the hospital. And it created such a psychological scarring on him that he was literally scared to see me as his doctor for several years because he thought I was going to do that to him. Versus with the mask and the spacer that I was talking about with the inhaler, as Dr. Lott said, you can give it in short few seconds to get the medication in. It's not that scary scene or miss. and you're able to deliver that medication effectively.
Right. And then even when you think about either children or adults, when you leave the house, right? Most people are not carting their asthma machine or their nebulizer machine around with them. So they are using it. I've had patients that only prefer the machine, so they don't carry a pump. But then when they go to the grocery store and something happens, they don't have it with them. Or they're at school and the nurse doesn't have a machine. And so they get stuck. So absolutely, I get your point. How have things with asthma changed with COVID? Is there anything different going on with asthma and COVID? Are you seeing more of it being triggered? What's happening?
So, Dr. Lott, I'll let you go answer. You answer first, I can answer later.
Well, from a adult asthma standpoint, and I'll specify because I don't deal with anyone under the age of 18, um, the change has often gone to, from a diagnostic standpoint, we've been very, I won't say reluctant, but a lot more diligent in how we order the breathing test to evaluate for asthma. As we all know, COVID-19, the coronavirus that's caused this global pandemic, is primarily a respiratory disease. It has a lot of different impacts in the body system, but a lot of the spread comes from aerosolization of respiratory fluids. So if you do a procedure or something that causes you to mist little bits of the virus from your lungs into the air, it can infect not only the person in the room that will be doing the breathing test, it could also impact another person that comes behind them having the breathing testing done. You're using a nebulizers to give this medication in small droplets to get all the way down in the lungs. Well, if it goes down in, you're going to breathe it back out. And that mist that you see has little virus particles just floating around in it, ready to infect the next person next to you. So that's one of the main reasons, some of the main things that have changed with the COVID.
One of the things we're seeing on the pediatric realm, and I'm sure that you'll also see this in the adult realm, pardon me, is that you have a lot more patients who are not seeking the medical attention that they need for symptoms that can easily be treated because of the fear of being able to become infected with COVID, because it is assumed that if you come into the hospital or anywhere close to a doctor or into a medical office, that you will most likely get infected with COVID. And so what happens is that especially for our children who have asthma, and especially around this time of the year, this is where we see a lot more of our asthma attacks, or what we call exacerbations, that occur. And so if they don't want to come in to seek medical attention, it's very difficult for me to be able to assess the child, or to be able to tell whether a child is in an asthma attack or if this is something else. Like I said before, you can sometimes see that infections like a cold can mimic an asthma attack. So it's very difficult to be able to determine, and that leads to having kids that may have worse outcomes, or maybe at a point in time where we would have a more severe asthma attack because it has been prolonged so far.
Got it. I remember growing up, I feel like we heard a lot more, especially in the Black community, about children or teenagers dying of asthma. I feel like it happened a lot more than maybe it happens now. Dr. Lott, could you tell us a little bit about why we don't see those numbers quite the same?
I believe that a major reason for that change in mortality has been the advent of more effective treatment, as well as a greater recognition amongst people that this is an actual disease and it can kill you. And if I don't get taken care of, I might not live. So I believe that the advancement of medical science with regards to treatments has really been had a significant impact on why mortality rates have dropped with management of asthma.
And may I also add in too, I think the reason why we're seeing a decrease in what we call fatal asthma, or the asthma where it would lead to someone who would have an asthma attack that they would not be able to recover from and dying, is because of the addition and the advent of things such as something called S-chip, which is the state children's insurance program that's being provided. So medications such as albuterol, such as the controller medicines that Dr. Lott was speaking to before, those medications are typically covered. So then children and families are able to get those medications. I can tell you, just even trying to find albuterol for my patients who don't have insurance, and there are still people who don't qualify for those programs, right? So
Hmm.
individuals who may not be documented will not qualify for those programs. So to find an inhaler that would take almost about $22 to $25 just for the inhaler. Now, for the spacer or the tube that I was referring to, that's an additional $30 to $40. So, for that medication to be close to $60 for a family who may have limited resources, it's difficult. And we saw that a lot of times, especially in the Black and Brown communities. And so when we would see that, we would do things such as, and I remember hearing about these things even from my parents, how if a child was having an asthma attack, it was said to make a strong cup of black coffee to give to that child because the caffeine within that coffee was very similar to the use of albuterol, but we know it's not as effective as that albuterol would be. So those are some of the boundaries, and one of the reasons why it's so imperative that we keep programs such as this to be able to have access to healthcare, especially within our communities.
Speaking of that, anything that you would warn patients against doing for their asthma? For example, I also remember there being issues with the over-the-counter, again, bronchodilators, the ones that will open up the airways. One of them used to be under Primatene,
Yeah.
one of the brands. It's back now. I had a patient bring it in and show it to me. Any thoughts about the use of that? Is it safe? Is it not? And
Yeah.
are there any other things that you want people to stay away from?
My thought about Primatene Mist is that it should not be used, particularly if that is your treatment for your asthma. It is over the counter, and I believe similar to how insulin can be purchased sort of over the counter for diabetics that are unable to afford, some of their controller inhalers. I can understand the reasoning behind it, but like any particular drug, overuse is detrimental to the effect of the drug. The best way that I can describe it, if you've ever had an uncle, brother, cousin, or just a bully that likes to, you know, pop you on your arm consistently, it hurts when they first start doing it. Over a while, you just kind of get accustomed to it. You don't feel it anymore. And that's because your body just kind of tunes out the sense. When you're using drugs like the Primatene Mist or even just albuterol alone, very, very frequently, the drug targets a specific receptor in the lung to cause that bronchodilation, cause the airways to open up so that the breathing is easier. The body recognizes that it's being used or stimulated consistently, so it brings the number of receptors down. So it's not as effective. So using it more frequently actually makes it less effective for you. If you are really feeling like you have to use that so that you can breathe and get through the day, to get through your life, you aren't controlled, and you need to get to someone that can help to give you or get you to a level of control. If it can't be done through your family doctor, you need to see a pulmonary specialist or a lung doctor or an allergist, a specialist that specializes in the management of patients with asthma, because there may be some things that can be done to help give you the control that will allow you to live your life as if you don't really have it.
And just to piggyback off of that, because Dr. Lott made a valid point, one of the other things that I try to warn my patients against, and I see this quite often, if you have a sibling or you have a cousin or you got an uncle or you got somebody who has albuterol, one size does not fit all. If it was not prescribed for you, don't take it. Because the one thing that I find is, especially for most of my parents who have multiple children, is if I prescribe something for one child, I might as well prescribe it for all the rest of them. Because they're like, well, we're going to divvy this up and give some of this because I know you're going to get this. Just the same way if one child has an ear infection and I give amoxicillin, which is an antibiotic, come to find out every other child gets a sip of that antibiotic as well because I'm just trying to preemptive strike you there. That's what a lot of people do for albuterol. Or they'll say like, oh, you know what? I know what asthma is. I have asthma. So I'm going to diagnose asthma in this person or that person who have no business or expertise to diagnose asthma.
Right.
Don't take those medications.
Right.
Yep. There's a lot of going along in that vein. People think asthma is, like we said before, one disease process, and there are a lot of different presentations. There's also a condition called cardiac asthma, which is a asthma-like symptom syndrome that's not an airway disease. They have heart disease. And if you use that particular drug, it can stimulate the heart that's not sick, or that's sick and not working effectively, and can cause you to have a heart attack. So just because you think you know what you're doing does not necessarily mean it's the case.
Right. Let a doctor diagnose you. Let a doctor do the test. That's the bottom line, right?
May I also say one other thing? Because this is an important topic that I try to teach my my patients as well. One of the things is that we have think about the respiratory tract or the tract where we talk about from the mouth all the way down to our lungs as being two different tracts. We have one upper respiratory tract, we call it, and one that's a lower respiratory tract. So lungs, lower respiratory, from the windpipe or the trachea all the way up to the mouth and the nose, we call that the upper respiratory tract. A lot of times I have parents that will come in to tell me, I heard my kid wheezing. When I ask them, like, describe to me how did the child look? Well, the child was fine. The child was sleeping and sounded and had the wheezing sound. A lot of times what they may hear is not wheezing, but nasal congestion.
Mm-hmm.
And so they will use the albuterol. And I usually ask them, well, when you use the albuterol, did it seem to help?
Mm-hmm.
And a lot of times when they tell me no, then I'm like, that doesn't sound like an asthma attack to me. The reason being is that one, if I hear audible wheezing or wheezing that I can hear without putting a stethoscope or even putting my ear close to your chest, you remember how your mom used to put her ear to your chest to listen to your chest? That's like what I always call a mama stethoscope or the daddy stethoscope, because daddies can do it too. Then if I can hear it with just my ears and you're sitting across the room or I'm just close to you, a lot of times you're really not that good off. Like, we need to get you in to see the hospital. So if you don't see that child needs to go to the hospital because their child's not working really hard to breathe, most likely that's not wheezing. Most likely that's something else. And it's important that you know the difference, that the nose and the mouth and even the upper airway can make sounds as well that's not related to the lungs.
And it can trigger it too, right?
Yes.
So you can have allergies that are just affecting you from the neck up, but if you continue with postnasal drip and you already have the setup for asthma, whether you have asthma or maybe you haven't been diagnosed yet, and that postnasal drip can also trigger lower airway symptoms, right?
Exactly.
Yep.
So I have another question for you, Dr. Winters. So of course you see them more when they're young, children, infants, small children, teenagers. Dr. Lott, you're seeing them as an adult. The million-dollar question is, can you grow out of asthma? Can somebody have it and then not have it? Dr. Winters, you want to go first?
So yeah, so actually, That is, I'll be inquisitive to hear what Dr. Lott answer would be as well. But in terms of the pediatric world, we do see that children will have symptoms of what we call reactive airway disease. So that means that certain things can trigger, whether it's viruses or if it is allergens, et cetera, like pollen and grass and such, that can cause for children to wheeze when they get, or cause them to have chronic coughs. Typically, what we find is around the age of 7 to 10 years of age, that type of response starts to decrease and starts to slow down, and we don't see that as often anymore. A lot of times it's because of the growth of the child. So those small airways, I like to think of it when I talk about the small airways in children and I talk about the mucus that can get stuck in it. Imagine like a coffee skewer. So the little coffee straws that you have, and you take a big wad of thick mucus that you spit out and you put it through there. And I'll tell you to breathe through that. It's very difficult, right? And that's how the little small babies are, like from babies all the way to 2, 3 years of age, little tiny holes, tiny airways. But as you get older, those airways start to get a little bit bigger. You start effectively being able to cough and bring up some of that mucus. You're effective to be able to blow your nose. And so you can grow out of that. But in terms of for someone who's truly diagnosed with asthma, you may notice that you're not having as many asthma exacerbations, may not have any at all. But the risk that you can have of potentially having a reaction never quite leaves. So you may see that even though it's rare that you may get one, there is still a possibility that you can get one. But I'll refer to Dr. Lott in terms of for the adult.
So, in my clinical experience, I see people that have been diagnosed as kids. They got better. Then around the age of 26 or 27, they start complaining of having symptoms again. I've had people that have never had it before. They have their 65-year birthday, and then they start noticing, I'm starting having, symptoms. We go through the workup, and lo and behold, they have a complex that would be consistent with asthma. So the current data shows that I believe worldwide between 1 to 20% of the population has asthma. And I believe that number is important because that's a lot of folk. Mm-hmm. That's a lot of individuals. But you may not know someone personally that has a lot of symptoms but may have asthma. And a lot of it has to do with what's their pulmonary reserve, what's their ability to handle the disease process. As you age and the lungs age along with you, you may have improvement in your function because that's just how your body's hormonal load, carries out. And you don't develop symptoms because, you've got the reserve to take it. Some people don't have that reserve. Some people become more and more symptomatic because they aren't able to grow past, or their treatment program isn't designed to treat the underlying cause of it. Ultimately, it all comes down to what's the cause? Is it something that's treatable? If it can be treated, bam, then your symptoms should resolve. And even with patients that are, what I consider long-standing asthmatics, I do work on trying to get them off inhalers if possible. The guidelines do recommend minimizing to the least amount of medication necessary to maintain control. So while we may have to go all the way up to, using the biologics and injections and all that other good stuff, really my long-term goal is to try to get you back down to maybe just using an as needed inhaler or a combination inhaler with a low dose steroid to help, keep the control where it needs to be. So ultimately, some people grow out of it and don't require, and some people get very well controlled on medication and come off of it, and the effect of the medication keeps them asymptomatic for some time, and then whatever the underlying cause that caused them to develop it in the first place starts to reassert itself, and then they develop symptoms again as they get older.
Mhm.
Or what I see in my world, either in the ER or urgent care, is someone who was diagnosed with it as a child, but every time they get a cold as an adult, they
Mhm.
cough longer than everybody else. They might start to wheeze a little bit, whereas their neighbor or their coworker that gave them the cold just coughed for like 2 days, and they're like, I cannot kick this. And you
Mhm.
listen to them and they're actually wheezing. And then I'll ask them, do you have asthma? No, I don't. No, I don't have asthma. Anybody in your family? Well, when I was a kid, they told me I had asthma. And then, so they only get disrupted when they actually are infected. I do see that a lot as
Mhm.
well. Awesome. So listen, thank you guys for joining me today. I think this was great. I hope that everybody out there, that you guys learned a lot more about asthma and how to control it. But thank you, Dr. Winters, Dr. Lott. This was awesome.
Thank
Thank
you so
you.
much for having us.